Welcome to the podcast called 22 at the Lips. If you are unfamiliar with this is the podcast from EMS providers to EMS providers, first responders, healthcare workers, and anybody and everybody in between. Today I have with me Chris from Canada. I'm going to let him say exactly where he's from because I am from the United States. I'm going to mess it up. Chris is a really cool guy. He's got 24 years of experience, which is almost as old as I am. Not only is that a lifetime, but it's a long time in EMS, and it is very honorable. So, Chris, if you want to tell the people who you are, what you stand for, go ahead, my guy.
Awesome. Thank you very much. I'm from Newfoundland, Canada, which is the most easterly province. So we're here, an island floating around, I guess, in the Atlantic Ocean. So yeah, I've been involved in EMS for 24 years as a medic. I did my first paramedic course, I guess. Here it's a little bit different, the levels. Like it used to be paramedic level 1, 2, and 3. And I did it in night school while I was going to nursing school. So, and this was before the internet. So we actually had to go into school 2 nights a week. So I've seen a lot of things change over the last couple decades. So I'm excited to be here and talk about intubation and rescue airways.
Awesome. It's a topic that is near and dear to my heart, one, because I'm just passionate about it in general, but also because I've personally experienced the ET intubation aspect. So it's a little bit of a personal aspect to me. But before we get started, Chris, I have some rapid fire questions for you.
Sure.
Just a couple of them, no big deal. The first one is going to be, what is your favorite thing about being a paramedic?
I guess my favorite thing is just being able to help people, whether it be the patients and their families, in their most, I guess, extreme times of their lives. Just being able to help them out and hopefully help them in, some little way and help them get through their crisis.
Very good. I feel like if you don't join the field for that reason, you're definitely not joining it for the pay. You're not joining it for the hours. Because who doesn't love working holidays?
Mm-hmm.
Second one, you are getting a new student to mentor. What is one thing that they could do to really impress you?
Oh, that's a doozy. I would say be honest in their questions and ask a lot of questions. If there's something that they don't know, just be honest and tell me. Like, that's what I'm there for, is to help guide them. The worst thing is if I ask a student if they're comfortable with something or if they understand something, and then I find out that they don't really understand. It's all about building trust, and I guess it needs to go both ways. Like, if for them to learn as much as they can from me, I need to know what areas they're weak in or don't understand. I think mentoring new people into the profession is a privilege. A lot of people are burnt out and see it as a burden. But to me, in order to help guide people into the profession and, make them as good as they can, we need to be there as mentors. And not only as a student, like I still learn stuff every day. And I think people that assume or feel that they're not going to learn anything every shift is pretty short-sighted. And I think the day that I feel I can't learn something is probably the day I should leave.
No, 100%. I laugh at the part about being honest, just because I think maybe my first shift, or it was just early on into doing clinicals for paramedic school. I forgot what it was, but there was something that my preceptor at the beginning of the shift was like, hey, let's go through a couple of things, make sure you know how to do XYZ. And there was one thing that I was like, oh, yeah, I know how to do that. And then we got on the call and I embarrassed the snot out of myself because I just kind of like stood there and I was like, uh, and I looked at him, I was like, um, I don't know how to do this. And the death glare that he gave me,
Hmm.
I don't remember what the thing was, but to this day, I just remember that pitting feeling in the bottom of my stomach. I feel that one got to me. And the last one, what is the best excuse for being late that you've used?
At work, you mean?
Work, personal life, what you get to choose.
Geez, I don't know. Um, the best excuse.
And I'm not taking notes on those.
Yeah, yeah. Nobody's gonna know. Um, I don't even know. I guess the whole flat tires seems to be a good one as long as you don't use it too often. So I don't know. You kind of caught me off guard with that one because you know it's tricky. We'll go with the flat tire.
I know somebody that, and it really isn't myself. This is not like somebody else. It really is somebody else that when they're stuck in traffic, they'll take a picture. And then if they're running late, they'll just send that picture. It's terrible. It is terrible. Again, just be honest. But man, is that smart? That's genius.
That is pretty good. We don't have a lot of traffic where I'm from, so
Oh, well,
it would be hard to use that excuse, but you should take a picture when it happens.
you start Googling pictures of traffic and just like
Yeah.
send that.
Yeah.
It's not even
Hope,
the right geographical area.
hope they don't look at the license plates on the vehicles.
It's like New York City. Okay, we'll go ahead and jump into this. So, in the core idea of what I want this discussion to be is it's the idea that at the core, in an attempt to simplify the basic, most core, and important aspects of patient care, you have your ABCs: airway, breathing, circulation. And like somebody told me one time, if you can do nothing else for your patient, you can manage ABCs. In the exception of a cardiac arrest, it's CAB, circulation, airway, breathing. Because if you're not doing compressions, you might as well call it a DOA, just being blatantly honest. But if your
Mhm.
patient does not have an airway, they're going to die. Then you have to go to CABs. Easy enough. Um, so proper oxygenation and ventilation is, long story short, what's going to keep your patient alive and improve the probability of stable neurological status in your cardiac arrest, but also when you get on scene and your patient's O2 sats are at like 80%, if you're not oxygenating and ventilating, again, you better go ahead and get ready to prioritize your CABs. And if we get nothing else out of this, I think one of one of the most vital aspects of all of this, never forget the power of non-invasive oxygen techniques. For instance, a BVM with an OPA, and slash or an NPA for your pre-oxygenation, proper suctioning and airway positioning. Because you can know how to throw an ET tube like nobody's business. You could have a perfect pass success rate. But if you're not going back to your BLS aspects of pre-oxygenation, whatever it is, the airway positioning management, you're not going to have that great of a success rate. And the post patient outcome is not going to be as impressive. And in anything, airway management ideas, never forget your waveform capnography. Even if you're not throwing down an SGA or an ET tube, if it is anything respiratory, I would even say like cardiac aspects, sepsis, anything where you're kind of worried about like oxygen levels, even sometimes on your stable patients, if you get nothing else out of this, whether you agree or disagree with what we say, do not forget your end tidal waveform capnography. Before and after you're choosing whether to throw down an SGA or an ET tube down a patient's throat, if you're not applying supplemental oxygen, if you're not focusing on anything else, you better be throwing on that end tidal capnography. Waveform capnography, it provides real-time feedback on ventilation. It shows you the quality of not even just airway, but chest compressions. And for me, at least, it's a visual aspect of what you're doing and if it's helping or not. So anyways, off that little tangent, off that, I'm going to kind of highlight the aspects of SGAs, supraglottic airways, and then let Chris kind of take over the endotracheal aspects of what we're going to talk about. Supraglottic airways. They are devices that are effective conduits for oxygenation and may offer protection from aspiration from your gastric capacities. Long story short, SGAs include, but are not limited to, combi tubes. And no offense, Chris, I'm not coming for you when I say this, but we don't ride on pterodactyls to calls anymore. So if you see a combi tube, and go ahead and take a picture of it. It's like a rare artifact in this field. You have your king airway, which it's a little bit newer. I'm not saying it's not as effective, but I personally am not a fan. If I see one on a truck, I may or may not throw it away if there's another SGA available. And my personal favorite, NI gel. I'm a huge fan, so I'm going to take precedence over that one. If you are listening or watching and you have any reason to believe that a king tube is better than an eye gel, please leave a comment. I would love to appropriately discuss why I agree or disagree. So an eye gel can be placed blindly into the esophagus or hypopharynx. It provides ventilation that's delivered through a port positioned above the glottic opening in the hypopharynx. It's got your cuffs that kind of inflate, again, providing that protection from aspiration from the gastric capacities. It does not mean it's 100% protective. Again, going back to your waveform capnography, you're suctioning, watching what you're doing, both visually with your patient, but also showing numbers and real-time feedback. And SGA is also effective and useful because it's, in the most core aspect, it is a rescue airway. If you can do nothing else from the get-go, you can throw down an eye gel. It's a confirmation of your initial and continuous waveform capnography. I don't mean this offensively, but it is an EMT basics skill at its core level, and 99.9% of registry aspects, service industries, agencies, and things like that, it is super beneficial to place it, in my opinion, and Chris, if you want to get input on this, in a cardiac arrest. You can literally get on scene, continue your chest compressions, throw it down, move on. That's just me. And like, I know some people, I don't want to say they get on a power trip, but it's like, oh, why would you do that when you can intubate? We'll talk about aspects when it's more important to intubate versus throwing down an SGA, but this is just me. I'm going to throw one down before I intubate. And if you have any reasons why not to, please go ahead, throw them in the comments. We'll talk about it. I learn something new every episode. There are cons. It's placed blindly, so it's not like you have direct visual of where it's going. It goes in the right space if you understand how it goes in. But At the same time, it is a blind placement. And kind of like we're going to talk about in a second, it's not really effective for patients with upper airway edema, such as with burns or anaphylaxis. One thing I hate about the king tube, the balloon over the inflation, like those cuffs, can also cause upper airway trauma and actually compromise circulation through the blood vessels in the neck. So you're affecting your ICP and things like that. We'll give it that much. And it's kind of the same thing with an ET tube. It may become dislodged. So then, like, you're ventilating the wrongest area and you're not doing anything proper. But if you're using end-tidal capnography, you'll be able to see that. So, Chris, I do want to ask, when do you decide whether an SGA takes precedence over an ET tube slash intubation and slash where it does not at all?
There's a lot of factors in that. There's patient factors, what's going on with the patient. Like you said, if they're in a cardiac arrest, compressions take precedence. So, positioning of the patient, where you are, where it is that you're trying to run this arrest. Do you have the room to get an, ET tube in place? What tools do you have? I don't think it's like a simple this that we could put in a table. Like, this is when you're going to use an SGA. This is when you're going to use an ET tube. I think there's a lot of factors in there that we need to consider. So I'm sorry, that's not really a definitive answer, but it depends, unfortunately.
And I think that's something that I kind of highlight just because, like, we can go back and forth all day long, but I also believe 100% that until you're in that specific call or that scenario, you can have your side of the argument, but it's dynamic, just like everything in this job, just like every single shift, every single call. No two calls are the same. So I think it also kind of depends situationally on what you're dealing with.
Absolutely.
So, Chris, if you want to talk about endotracheal intubation, all of the beautiful things about it, because again, not trying to say that we shouldn't intubate, you should in your cases. And kind of like you said, the space aspect, the time aspect, there's indication for it. Anybody that says that paramedics should not intubate, I'm not saying that I want to throw down with you, but also no. So, Chris, if you want to talk about endotracheal intubation, take it away.
Sure.
Go ahead, my guy.
I think, I'm always going to side on, and you'll hear this argument time and time again, that anything outside of a cuffed ET tube through the cords is not a definitive airway. So a definitive airway is always our goal, but we also need to realize that there are times when we're not going to be able to get that. So, and there's a bunch of different factors in that. I think the tools that people have is a big thing, especially with, like, in where I work, we have video laryngoscopes, which is a game changer for being able to intubate somebody, especially trauma patients. We have full RSI capability. We have multiple different induction agents that we can use depending on which patient, like, the way that they present and what's going on with the patient. So I feel like the majority of time when we're going to capture somebody's airway, it's going to be intubation. But we also have the tools and the experience to do that. And we also, like, in our team of two, typically it's a nurse and a medic. And I know some places in the US, there's a lot of people that are dual trained. But that's not common where I am. Like, I'm dual trained, but I actually had to do, like, all the different levels of paramedic. There's no bridging programs here in Canada, but that's a different topic that we can talk about. But both providers in our team have extensive experience in DORs, getting intubations, and in the emergency departments getting intubations in adult and pediatric. So I think the way your system is set up also has a lot to do with how successful the provider is going to be. Like, do you have those extra tools? Do you have a robust training program where anesthesia and emerge physicians are involved with your training and also your skill maintenance? I think if you don't have that, that makes it harder to be able to get a definitive airway every time. And we used to use intubating LMAs as our backup, and we're actually just gone to the odd gels now. Probably just because of a supply issue. I don't really know the exact reason for it, but the ground system uses odd gels, and you know, the logistic guys are always peeved with us when we're like, we need these intubating LMAs and we need these special tubes for them, and they're always like, well, why don't you just use the odd gels? So I think they won the battle with management, and now we're going to odd gels instead of the intubating LMAs. But you know, they have their pros and cons. But like you said, you know, the odd gel is by far the superior supraglottic airway now, and the superior rescue airway. If you can put in an OPA, you can put in an odd gel. So I'm a big supporter of both, but I'm always going to try to get a definitive airway with an ET tube if I can. And even in kids now, we're using cuffed airways or cuffed ET tubes. They're micro cuffed, and we might not always inflate the cuff, but they are cuffed. So yeah, I hope that answers your question.
Yeah, no, totally.
Without going too far one way or the other.
No, it's fair. I apologize to the agency that I work at. I'm currently about to move to Canada for the visual intubation and RSI capabilities. It's been a real great time, but no, I'm just kidding. So, kind of like you said, it is a more definitive airway technique. It is not your end all be all, because you can miss your tube. And if you, like somebody said one time when I was like, oh yeah, sometimes I miss a tube and here's how to improve. I think it was a joke, but I was told like, just don't miss it. Oh, okay. Will do. And you can practice, you can improve your skills. There's always room to improve, there's always room to learn more, kind of like we already said. But I'm not going to say it's inevitable at least once, but it does happen. Even the most skilled providers miss some tubes. It's a very tricky skill, and no two airways are the same. And we do practice with plastic dummies who have a perfect airway every time. There's no need to use the salad technique. There's no need to like reposition the airway 6 times, place like 6 towels under your patient's shoulders to make sure that they're in the right position. Anyways, and again, personal aspect to me, you have your airways that require an intubation over an iGel or an LMA or a King tube. Again, burns, traumatic head, face, neck injuries, anaphylaxis, as I have been personally endeavored in. So you can miss a tube, and then you're just inflating the esophagus. Again, if you don't have your waveform capnography, you will not know for 100% sure. Anyways, intubations, but also iGels, you have that risk of causing damage to the teeth, the mouth, the tongue. In my personal experience, when my right vocal cord got paralyzed one time. So for like a month straight, I had a raspy voice and I couldn't talk above a whisper. Anytime we were on a scene, I'd have to like lean in really close to a patient or the firefighters, and they'd be kind of like looking at me, and I'm like, talk about this. It did, obviously it went away, but in my side of the story, I'd rather have that and be alive. I mean, I'm not going to say you should tell your patient, like, sorry for your teeth, go get some dental work, at least you're alive. But when we take it into consideration, and then with your SGA, it only goes so far. However, and in your main stem intubation, 9 times out of 10, you'll end up going to the right just because there's the 3 lobes versus 2, et cetera, et cetera. And again, if you're using your waveform capnography, you'll be able to tell almost immediately. Use your freaking capnography. And it's also one of your ways of confirmation. But anyways, besides the obvious of time management, your provider's level of experience, I'm not going to say one exceeds the other. However, I think there's more pros versus cons of endotracheal intubation over an SGA. Even though I praise the iGel, I heavily support it. And if your agency does not have it, I'm not going to say get with the times, but I think that prioritizing patient care over the financial aspects is more important. But again, time management, your spatial interactions, there's many deciding factors. So to kind of wrap up, 1, whatever you do, use your pre-oxygenation, use your basic interventions of capnography. And I think it's important to go to that BLS before ALS. Again, prioritizing your ABCs or your CABs, but just kind of take a step back and look at where you're at, what you're doing, the situation, and you can kind of go from there, in my opinion. So, Chris, if you have anything you want to add, that's all I got.
No, I think that basically covers everything. One advantage too with the SGAs that I just thought about over just bag valve masking and OPA is typically with a lot of patients now, you almost need 2 providers to do BVM just because, that's what they're recommending now is, 1 person holding the mask and 1 person ventilating. So by using the SGA, you also bring that down to 1 provider. So typically they'll be able to do it single person versus having to have 2 people tied up with that.
I didn't even think about that. Yeah, because you got one that like you're making sure you have that good seal around their mouth and nose, and then you're doing one that's like using a BVM. If you have that ability, it's super nice. 20 out of 10 recommend, but kind of like you're saying, that's a dream world and not always accessible. So if you have anything you want to add, if you have anything you want to disagree with, throw it in the comments. I would love to talk about it. I think it's a valid, I'm not going to say argument, but something to heavily consider in this field because airway management is our first step besides any cardiac arrest. It is our first step of managing our patients. So Chris, if that's all you got, that's all I got. And we'll wrap it up the same way we do every single episode. So with that,
the 22 at the Lips podcast is designed to support, not replace, the relationship that exists between a practitioner and his or her medical director. The views and opinions expressed in this podcast are those of the host, guest, and not necessarily of Master Medics. The information provided during this podcast is intended for educational and informational purposes only. It is not a substitute for your approved protocols.